Welcome to our Beyond 20 campaign, a celebration of One Joshua Group's 20 years of service excellence. This is a One Joshua Group production, providing access to information and experts to help improve quality of life and health outcomes.
Thank you for joining us. Today we have Dr. Donald J. Alcendor, and Dr. Alcendor has been our guest on previous podcasts. And Dr. Alcendor is the Associate Professor of Microbiology, Immunology, and Physiology at the Meharry Medical College. Welcome, Dr. Alcendor.
Thank you for having me.
So the topic today is a very important and timely topic. It is on viruses and vaccines. We want to talk about the development in vaccines and viruses, and we want you to tell us about the resurgence of diseases and how we should prepare for vaccines and viruses going forward.
Yeah, so I think the first one that we would have to talk about is polio. And so we haven't seen cases of polio for decades. I mean, the only polio vaccine that's available to you now is the inactivated virus for polio. But again, it's very good that we're continuing to give polio vaccines to children because we have seen a resurgence. It also says there's been a change in the way we surveil for viruses that reemerge. And one of the things that allowed us to pick up this polio reemergence is the testing of wastewater. The idea is that this will become something that will be very common going forward. The idea of testing wastewater gives you a heads up in terms of the virus components that might be there. It turns out that polio is one of those viruses that initially starts off in the intestinal tract. So you will find polio virus in feces quite readily. But again, the nerves are involved, and of course, paralysis can happen in a certain small number of people that get polio. So the idea is that being able to surveil for viruses will give us an opportunity to understand the dynamics of reemergence of viruses over time. And COVID has taught us an important lesson that the concept of herd immunity can be put aside when it comes to COVID. And the reason being is that when you think about herd immunity, you think about a virus that you can completely control by vaccination. And the idea with polio, with COVID, this virus could not be controlled completely with vaccination for the fact that we had reinfections and we had the emergence of different variants. And so with that, we're still seeing COVID infect people. We're still seeing people dying of COVID. And even now, we're seeing an uptick in COVID, and we've seen this as part of increase in hospitalizations and disease across the board. And so you may even see the implementation of masking, in ways like we haven't seen in a while. But what we are experiencing now is that we're experiencing the fact that so many people have been vaccinated. We have a shield of immunity across the country that allows us to go unmasked. However, we're at the risk of losing that shield because of a virus that continues to change.
Mm-hmm. So, Dr. Alcendor, when we look at viruses, HIV, RSV, tell us about vaccination and the way we address some of the changes in those two diseases.
Yes. So when we look at certain diseases like HIV, we have tried for a very long time. A lot of money spent, a lot of very smart people have tried to come up with a vaccine that could protect against an HIV infection. That has been difficult over the years. From the early days of the 1980s, this proposal at that time that a vaccine would be available very soon. And so the Secretary of Health came out and said that in public display that this was an infection and we would have a vaccine relatively soon. If we move ahead more than 40 years later, we haven't seen a vaccine that's efficacious for HIV. The idea is that when you think about the best result that we've got with the vaccination for HIV, we're looking at about 37% effectiveness. And so when you have a vaccine that's 37% effective, it's not relatively good for the general public. And so we have to improve on those numbers. We saw something else happen during COVID is that a vaccine sometimes is so important in terms of it's a necessity within a very short time that we need a vaccine right away. At the height of COVID in April 2020, we were looking at 5,000 people dying every day. We're talking about 50,000 people dying in 10 days. And so this was the turning point. We needed a vaccine relatively quickly. And the only way that would happen is that you would make money no object and you would give the best players an opportunity to meet a very difficult goal that many people thought they couldn't do. But the idea of thinking that you could generate a vaccine outside of the regularly scheduled time limits for vaccine development, which is anywhere from 5 to 15 years, they were asked to make that COVID vaccine in less than a year. There were two companies that were able to accomplish that, Pfizer and Moderna, and they got rewarded for that quite readily. And so the idea is that we need to make vaccines better. We need to make vaccines more safe and effective. We need to be able to mobilize a vaccine platform very quickly. We saw during the monkeypox outbreak in 2022 that vaccine stocks were at a very low level and not available for people that needed them. So what we have to do also is make sure that our vaccine stockpiles are up to date and ready to be mobilized to protect the public.
So let's step back a minute to COVID and availability of vaccines and how we participate in that. Now, Dr. Alcendor, if you've gotten 4 or 5 boosters or 5 and 4 boosters, how can we encourage people, or better yet, convince them that although it be another one, that is important that we, participate, comply, if you would, in getting these new vaccinations?
So I get this question every time at vaccine events. And they're telling me I've gotten so many shots. But I tell them, how many people do you know that's been vaccinated that got infected again with COVID? That gives you an idea that the vaccinations that you're getting are not 100% foolproof in terms of protection. But then again, I asked them this: how many of the people that you know got reinfected and has to be hospitalized with COVID? They will tell me none. What it says is that the residual protection against the vaccines, even those that have waned, will still protect you from severe disease and hospitalizations. And if you're sitting there with underlying comorbidities, that puts you at higher risk for more severe disease with COVID if you get it, because you clearly know that you can be reinfected. And at the same time, we have variants that are developing out there. You have to be vigilant in terms of protecting yourself before you would experience one of these new variants that could evade the antibody response you had to a prior vaccine.
So that variant, is that EG5 we just heard for the first time? What happened to 1, 2, 3, and 4? How did we just get to 5?
So what happens is that over time, we have to go back to the ancestral strain of virus that came out of Wuhan, China. And the idea is that ancestral strain is no longer circulating in the population on a global scale. Many of these viruses, like the Delta virus, that so many people died of because this virus is so highly infectious, and the mortality associated with Delta virus will be legendary when we talk about COVID in the future. And the idea is that over time, these viruses are not able to sustain itself in terms of infectivity, meaning that you have so many people that have been infected and have produced an immune response, and you have so many people that have been vaccinated and have produced a robust immune response. The virus now is left unable to sustain its ability to replicate in the general population. So over time, the virus, as you would say, dies out. And it's the same thing you would see in a herd of cattle that need to be vaccinated. And the so-called herd immunity, if you vaccinate enough of your cattle against the disease, over time, there's no more cattle for the virus to find to sustain itself in the population. Now that population becomes sterile unless a new form or a different virus is then introduced into that population.
So I read here that you were in microbiology, immunology, and physiology. I didn't know that you were a mind reader as well, because the reference to herd immunity was going to be my next question. So
Yeah.
herd immunity, wearing a mask, not wearing a mask, help us
Yeah.
understand that.
So when we start to talk about herd immunity, and this is something that came out of Tony Fauci's mouth a lot, my mouth a lot when I was talking to people, and the whole idea is that you would have a virus that you would develop a very good antibody to, in terms of being able to basically inject a person with a vaccine. They would develop antibodies that would be protective. We call neutralizing antibodies.
Mm-hmm.
And of course, if you got one single virus that's not changing, that's reasonable to assume that that will happen. And so it's just like I talked about the cattle, you have enough people vaccinated so that SARS-CoV-2 could not find a place to basically maintain itself in the general population. That all went away when we found out that the emergence of these variants just continued in the general population. You see, a virus, what it will look for, it's pockets of the population that are unvaccinated. At the same time, SARS-CoV-2 does more than that. It looks at pockets of the population that are highly vulnerable to reinfection. And so the idea of herd immunity becomes a misnomer when you're talking about SARS-CoV-2 in its ability to reinfect, its ability to change, and its ability to not go away. So when we think about influenza, influenza is seasonal, meaning that we won't see influenza very much in the summertime. That's clear. SARS-CoV-2, from the beginning, everybody thought that it would disappear when the hot weather came. But what people didn't notice is that in countries like South America, like Colombia, where in January and December it's 95 degrees, they didn't notice there was death and destruction due to COVID-19 in Colombia during the cold months and during the hot months as well. And what it's taught us is that this virus is here to stay, and it is trying to make a claim of 50 to 60,000 lives on a regular basis annually in this country. And I feel that that is unacceptable.
I think so. I want to ask you again about mask.
Mm-hmm.
How, and I know that that's an individualized decision.
Yeah.
What is your recommendation about to mask or to not mask?
Yes. And so it starts with the person. And that is, if you're a person that has underlying conditions, particularly respiratory ailments that are chronic, COPD, interstitial lung disease, asthma, bronchitis. You have maybe multiple comorbidities like hypertension, diabetes, obesity, again, is a condition that puts you at higher risk. So if you have multiple conditions that put you at higher risk for the most severe complications of COVID, then I think you should mask. If you are in a situation on a constant basis where you're in around the public in large numbers in places that are poorly ventilated, I think you should mask. If you certainly have had a bout of COVID and you're recovering, you need to mask, and the people in your household have to recognize that and be masked around you until the appropriate time when you're no longer infectious. And again, I would say anybody, if you're sitting there and you're not up to date on your booster, you ought to be concerned. And for that concern, you should mask.
So Dr. Alcendor, so we see these acronyms, mRNA, and I know that in your engagement in the community, and thank you so very much for what you do in the community, help me understand that. What does that mean? What does mRNA mean to me and my susceptibility to viruses?
Yeah. So when we say mRNA, we're talking about messenger RNA. So every cell in your body will make proteins. And the idea, it makes these proteins via a particular structure from its DNA. That DNA that encodes a protein in the cells of your body translate the DNA message into an mRNA message. that mRNA message is a message that is in such a way that their proteins called ribosomes can get and engage this mRNA and makes the protein for you. And so mRNA is that form of a transcribed DNA message that allows a cell to make proteins. Now, the mRNA vaccines have done something not to give you the protein itself, but give you the mRNA that is the precursor of a protein. You see? So the mRNA is a precursor of the protein as opposed to giving you the end product that is the protein itself. So it's saying, we're going to give you the mRNA that encodes a particular component of the virus. In this case, for COVID, the spike protein. Now, when we give you the mRNA as an injection, your body will convert that mRNA into the foreign viral protein. You see what I'm saying? Now, you might say, why not give the person the protein itself? It turns out when you give them the mRNA, the body will make this in a very efficient way very quickly. And that mRNA is destroyed by the body in a very short time after that protein is made, because that's important as well. You don't want the mRNA to hang around getting into trouble or doing something it shouldn't. So the body automatically destroys that mRNA after it makes the protein. So it's like the rabbit out of the hat, and the hat is destroyed. And the idea is that it allows you to make this protein in very efficient ways. And if that protein has certain specific conformations that are important to be recognized by the immune system, the mRNA will do that for you as well. The idea also is that if you have to prepare many different vaccines right away, the mRNA platform allows you to do this in a very quick way. And so this was the idea of the original companies, that is Pfizer and Moderna, is that if we design this as part of our as an mRNA, we can make changes in that mRNA very quickly to basically mobilize a new vaccine that would be protective against an incoming variant that is very different than the public saw before. So the mRNA platform is a modular one. Being modular, it can be modified within 2 to 3 months to get you a new vaccine that will be able to combat a variant or some change in a virus or an infection that the public are not aware of, and their immune system is unaware of as well. Does that make sense?
It does. It's a dry run. It's a trainer.
Yes.
It's trying to train the body. And
That's right.
the genes. Yeah.
It's a precursor.
It's a precursor.
But in the end, your body goes ahead and make that protein, and then now everything is in place, and everything is ready to go.
So new vaccines, HIV and cardiovascular disease. Can you just talk to us briefly about those new?
Yeah. So the new vaccines, what you're looking at is a new way of making vaccines and being able to look at making multiple vaccines in one shot. And so that's what you're going to see in the future. And of course, there's going to be vaccines for immunotherapy as well. That is to treat conditions like cancer and so forth. There are vaccines to do that as well. And of course, we know that vaccines, a virus has been employed in vaccines, particularly in the Johnson & Johnson vaccine. That's a vector-based vaccine where a virus was used to deliver a protein. And of course, the AstraZeneca vaccine, which also a viral vector that is used to deliver a protein as well. But when we think about vaccines that are changing, we have to say that the mRNA technology has introduced something that's very interesting. What it does is that it introduces a modular way of making vaccines that you can change very quickly. At the same time, it increased efficacy that we've seen with the mRNA vaccine is something that people cannot turn away from. When we look at the effectiveness of the influenza vaccine in the general public, we're looking also, I would say about 45 to 55% on an annual basis. That's how effective that influenza vaccine is. But to see an mRNA vaccine against COVID at 94 and 95% effectiveness, this puts vaccines on a different level with that kind of efficacy. That kind of efficacy could improve say, a novel HIV vaccine that is delivered as an mRNA vaccine. And so this is what we're hoping for. And at the same time, people don't want to take so many shots. And so the idea is that what I want now is to get all of these vaccinations in one shot. And so the vaccine companies have heard those complaints. And so what you're seeing now is multivalent vaccines. This will be a thing of the future. And we've seen it all along, but nobody's put it into play. But the mRNA vaccines are allowed to do that, where you have multiple cassettes of mRNAs that will encode a protein for respiratory syncytial virus, or RSV, COVID, and influenza, giving that all to you in one shot. Now, this would be great. And it's very important for people that don't like multiple vaccines, don't like to make multiple appointments. And of course, there's quite a bit of people that are out there that have a fear of needles, and they won't have to get stuck so often.
Well, now you just mentioned, I think, a large percentage of why people don't get the immunizations because of the fear of needles. That's something I think that we're going to have to work to help people overcome. It's always a pleasure to talk to you, Dr. Alcendor. We congratulate you and thank you for the work that you do in the lab and the work that you do at the bedside, and also the work that you do in the community. They tell me that I'm supposed to recap this conversation, but I think you said it all. I get concerned about recapping because I may miss something, but we thank you, and we're going to have you back. And you've been listening to and watching Dr. Donald Alcendor at Meharry Medical College. Dr. Alcendor, thank you so very much for what you do.
Thank you for having me.
And we will get to speak to you again soon. Thank you and have a good day.
This edition of Beyond 20 is a Life Beat podcast sponsored by One Joshua Group, your strategic source of engagement to improve life through better health, education, and information. For more information, visit us at theonejoshuagroup.com or follow our work on LinkedIn, Facebook, Instagram, and Twitter using hashtag OneJGCollabs. One Joshua Group, building capacity, expanding resources, joining what you know with what we've learned.